Firstly, I would like to thank the eCancer for the opportunity to be here today with you all, and let me present this topic and my vision of future for the upcoming years in this field, and maybe how we can join forces through the education. My name is David Martinez, and I'm originally from Colombia, currently working as regional integrator of methodologies and practices in radiation oncology at AUNA Network and Director of Education and Training for Latin America at Radios Contra Cáncer. Today, we will present a topic about breast cancer and emerging indications for intraoperative radiation therapy. These are my disclosures, nothing to declare for this presentation. Before we start, let's say that the difficulty lies not so much in developing new ideas as in escaping from old ones. I would like to show you geographically where we are located, and always keep in mind our mentors who started this journey more than 35 years ago. I'm not here in defense of IORT. I'm in defense of patients, biology, and optimal treatment. What type of treatment would we have available to perform with IORT? So we will talk about IORT as definite dose for accelerated partial breast irradiation, IORT as boost, IORT for patients where EBRT is not an option, re-IORT for recurrent breast cancer. So in which clinical scenarios could we evaluate IORT? So IORT as accelerated partial breast irradiation is mainly focused on replacing EBRT and those having a shortening of the treatment. IORT as boost, like dose escalation to external beam radiation therapy. The first studies we have on IORT as accelerated partial breast irradiation will be the Target 8 and Elliot. We can see translational studies that have shown beneficial effects on the tumor microenvironment by inhibiting cells migration, proliferation, and adhesiveness. As you can see here in this graph, we have multiple alternatives to perform APBI, such as interstitial brachytherapy, external beam radiotherapy, intracavitary brachytherapy, which could be analogous to the IORT we are talking about today. In breast cancer, intraoperative radiation therapy is a radiobiological improvement as it is administered during the same surgical act, a selective and intense irradiation without geographic loss of target, reducing toxicity to adjacent healthy tissues, demonstrating results that are not inferior to conventional treatment, as we will see further in this presentation. So, scaling and descaling breast cancer treatments. In this graph, it is commented that the IORT could have an increased rate of local recurrence with a follow-up of 2.4 years, compared to the classic study of interstitial brachytherapy performed by Jack Estro within 5 years of follow-up and 1,184 patients. So when analyzing in depth the Target A study, we can observe that at least 1,222 patients had a mean follow-up of 5 years, taking into account that cutoff point of non-inferiority of IORT compared to EBRT was 2.5%, even lower than the 3% taken by Jack Estro in their study. It should be noted that when we analyze separately the cohorts predefined in the target study as pre-pathology and post-pathology, those in the prepathology stratum had local regional recurrences of 2.1%, which is below the cutoff point stipulated by the study and not inferior to standard EBRT treatment, as we can see in this graph. So IORT should be performed expressly at the time of surgery, and the postpathology stratum has not been used for years. When we are planning the boost in patients who have it indicated, we are mainly guided by the surgical clips. However, when patients undergo conservation surgery and oncoplastic maneuvers, this can alter the location of the boost, so we wonder where to irradiate in these cases. Studies conducted by the Salzburg Breast Cancer Center perform as a standard treatment boost during conservation surgery for all risk groups were technically possible more than 3,000 patients, prospectively documented and retrospectively analyzed. Focus on long-term analysis, subgroups analysis, and possible combinations with hypofractionated schemes. Showing the results with a mean follow-up of 72.4 months, the local control rate was 98.5%, with only 1.44% local recurrences, even showing that this benefit is maintained even longer, even with longer follow-ups, such as 10 years. Although statistically it is difficult to make it direct comparisons between treatments, treatment techniques, if we take the results of the classic study by Bartelink in 2007 on the benefits of boost in different age groups, and we superimpose the results of boost with IORT in these same subgroups, we could observe that there are benefits of boost in all groups regardless of age. This is important because if we compare the local recurrence rates in the different studies on the outcome of local recurrence, we see that IORT has the best outcome in this scenario. Here we can observe a study on boost with IORT with an average follow-up of 15 years. 400 patients with follow-up up to 15 years collected from 2002 to 2014, with a mean age of 63 years, interval between IORT and EBRT of 48 days. 35% of these patients had chemotherapy within the treatment scheme, and 83% received endocrine therapy. It is important to underline that within this cohort, there were also patients considered high risk, such as M-positive, T2 tumors, G3 positive margins, HER2 positive, and triple negative. When we compare the results of IORT with the classic ERTC study in terms of local recurrence, they are similar. However, we observe an important impact in terms of decreased probability of metastasis and increased overall survival. Some results from our experience with IORT. The main objective is to describe the results of using IORT with 50 kV photons to tumor bed with or without adjuvant EBRT in patients undergoing conservation surgery. A total of 162 patients were included. Patients were stratified according to the target inclusion criteria for A, B in groups, and dose of 20 gray in one fraction was applied as the only treatment in the first group and as a boost in the second group with subsequent EBRT. The following baseline characteristics were evaluated: age, tumor size, lymph node involvement, stage, locoregional irradiation schedule, time to initiation of teletherapy, the time to detection of local and distant recurrence after completion of irradiation treatment was determined. Overall survival from diagnosis to death was determined. In addition, a strategy for the rescue of recurrence was determined as well. These are the basal population characteristics. Half of the patients received EBRT. Of those, half were treated with hypofractionation schemes. We can see that it's not an increase in toxicity, and we had 2 patients that recur in non-breast sites, one in lung and other one in liver, that were salvaged with SBRT techniques. So median age of 58 years, average applied use was 3.5 centimeters size. A recurrence-free rate of 98.8% was obtained, and 2 years of follow-up, when a mean overall survival of 2.2 years in our cohort. Therefore, in our protocol, based on different international guidelines for the case of IORT with photons, this would be the criteria to perform it as APBI or as a boost. That it can serve as a guide for other institutions that wish to implement its use. As a conclusion, the use of IORT has been shown to be at least not inferior to external radiation therapy in APBI modality. As boost modality appears to offer benefit in local control, distance, and overall survival in patients with unfavorable immunophenotypes. More follow-up time is required to consolidate the impact shown in results, minimum complication rates, excellent cosmesis, and local control, which allows us to infer a positive impact on the survival and quality of life of our patients. Other applications for IORT, for example, in pancreatic cancer, we know that the major site of recurrence of operal pancreatic cancer is local, being the biggest issue the retroperitoneal margin in this scenario. There is a substantial increase of publications on IORT over the years, and pancreatic cancer is one of the important locations for its use. We see how local regional control is superior in those patients who receive chemoradiation with IORT than without it. But it should be noted that disease-free survival is impacted if chemoradiation was administered as neoadjuvant versus adjuvant approach, and overall survival impacted when surgery is R0. Therefore, the best strategy in this scenario will be the administration of neoadjuvant chemoradiation followed by surgery plus IORT with our R0 surgeries. When resecting a tumor, we have safety margins that may be occasionally may be compromised, where IORT can help us with the sterilization of these additional margins. This is our theater where we carry out the IORT treatments, and some pictures on where and how we place the applicator in the tumor bed where we wanna do IORT treatments for pancreatic cancer. Also, we can use softwares that allow us to calculate the doses in depth and later make the biological summation in cases where it is required to complement with external beam radiation therapy. This was the team with which we performed the first intraoperative radiotherapy treatment for pancreatic cancer in Peru. So IORT is radiotherapy, is feasible and tolerable. Is precise radiotherapy able to be planned and registered? Is a precise component of RT for dose escalation with local control up to 90% in patients with surgeries at R0, and more than 60% local control in patients that have positive margins. Is an efficient alternative for RT dose de-escalation in patients that has R0 surgeries with local control up to 95%, and adds a biological safety margin to surgical resection, does not interfere with systemic therapy. This is our current approach for pancreatic cancer patients, where IORT have a role in resectable low-risk disease. Other applications like ocular conjunctival carcinoma. So primary treatment of conjunctival carcinoma lesions are surgery, excised with a 4 millimeters margin, dissecting down to the sclera without touching the tumor. Recurrences after the primary excision can be frequent. Surgical excision alone is associated with recurrences of 3.2% to 67%, an average of 32 months of follow-up, depending on the tumor size, the margins, the adjacent structures, and also if the margins are less or over 5 millimeters. Adjuvant therapies to augmented surgery included cryotherapy, where 2 to 4 freeze-thaw cycles are used to obliterate residual tumor at the bed and margins. Topical cytotoxic drugs such as 5-FU and mitomycin C may be applied to the bed for about 2.5 minutes, then wash off. Other agents included interferon alpha 2B drops, cyclosporin A, all trans-retinoic acid, anti-VEGF agents, and radiotherapy. This is an example of the procedure where we place a flat applicator in the conjunctiva. This study was made in Peru by colleagues from the National Institute of Neoplastic Disease, enrolled 39 patients with squamous cell carcinoma of ocular conjunctiva, tumor size T1 to T3. All of those were resected. The doses used were 18 gray for patients with free margins and 22 gray for positive margins, according to the calculation of equivalent dose of 2 gray per fraction of 46 and 66 grays, respectively, assuming a tumoral alpha-beta ratio of 8 gray. The prescription was done to 2 millimeters in depth. Mean time between surgery and irradiation was 1.5 months. The dose was not statistically related with toxicity, and the 1-year disease-free survival was 96.7%. So, based on this study, kilovoltage surface brachytherapy is an applicable and reproducible tool in the treatment of squamous cell carcinoma of ocular conjunctiva. The administered doses are well tolerated by patients with low levels of acute toxicity, but longer follow-up is needed to establish disease control rates and late toxicities for these patients. Other site where we can use IORT is glioblastoma. So the incidence of this disease is 3 to 4 per 100,000 inhabitants. Median age of 65 years, most common malignant primary brain tumor in adults, and the standard of care has not changed since 2005. And the median PFS of these patients is 7 months. So local recurrences are predominant pattern of failure, 90 to 95% within 1 centimeter to the cavity. There are some prognostic factors like age, KPS, MGMT mutation, IDH1, and of course, the extent of resection. So as I said, the recurrence pattern hasn't changed for 30 years. And there are studies showing a dose-response relationship in glioblastoma, opening possibilities for the dose escalation radiotherapy strategies. So we will see the use of IORT with low energy X-rays in these cases. So glioblastomas classically arises within an hemisphere of the cerebrum. Following resection, macroscopic and microscopic residual tumors give rise to local recurrence. The dominant failure pattern in glioblastoma, IORT using low energy X-ray delivered by a spherical applicator sterilizes 5 to 6 millimeters of the cavity margin depending on the radiation dose, while preserving underlying brain tissue due to the low penetration depth of the photons. As you can see here in the graph, the dose distribution of all applicator, note that the low energy X-rays are absorbed within the first few millimeters of tissue. 50% of the total dose is absorbed within 3 to 7 millimeters. Treatment of the resection cavity with low energy IORT. Following dropping a suitable applicator is chosen that ideally fills the whole cavity and has contact to all cavity margins without squeezing healthy brain tissue. And the system is inserted into the cavity, as you can see in the pictures. So we started with the phase 1, phase 2 study that its name is Intrago. This was a study where we pulled where we did an analysis of an international pool analysis of 5 centers in Germany, Peru, and China, where we had 51 post-resected confirmed glioblastoma patients treated with the standard of care plus IORT, with a median follow-up of 18 months. So as you can see here, we have encouraging outcomes with an annual rate of overall survival at 3 years of 25.6%. And you can see that the main pattern failure wasn't local. Instead, as you can see, is distant. We have distant recurrence further than 1 centimeter from the surgical bed. And there is not an increasing toxicity in these patients. The response patterns of patients after IORT plus standard of care therapy, as shown, are T1 weight MRI scans from 6 patients treated with IORT and a standard of care, indicating that the predominant pattern of failure was distant progression, as I said before. Some schematic illustrations and examples of perilesional contrast enhancement patterns on post-contrast T1 weight image in patients after intraoperative radiation therapy and following standard radiochemotherapy. It is important to notice that in picture A, there are no contrast enhancement. In picture B, a thin linear rim. Note the satellite lesion dorsal of the resection cavity, and C, a small nodular captation. D, combined linear and nodular captation, and E, voluminous indistinct mesh-like. C, D, and E are compatible with possible patterns of local recurrence that must be followed by MRI with diffusion, perfusion, and FET-PET to distinguish among local progression or radiation necrosis. So in summary, Intrago phase 1 and 2 trial testing outcomes of low energy IORT to the cavity margin added to the standard of care included mostly incomplete resected patients and patients with salitated lesions not targeted by IORT. Low energy IORT has a manageable safety profile. The median PFS was 11.3 months, and median local PFS in the patients treated per protocol were 18 months. We have an overall survival of 18 months in the patients seen in the pooled analysis. Most patients died from distant recurrence and satellite progressions. A new study, phase 3 studies is being done in Tragos. It's a multinational randomized phase 3 trial open to recruitment in Canada, Germany, Brazil, Spain, and the US nowadays. So IORT definitely is a team effort. So in summary, an overall available data on IORT shown a favorable impact on local control in selected tumor site and in overall survival for combined modality treatments. However, despite the several thousand of patients treated, limited level of evidence are available in supporting recommendations. Technological advances allow an extension on IORT clinical activity with the possibility to prove its efficacy in well-designed clinical trials, as in breast cancer, how we see it. So, what to do? Multidisciplinary cancer care is the answer. Because together, everyone achieves more. This is our regional RT team, whom I'm honored to work with. Many thanks for your attention. And again, many thanks for the invitation to this wonderful activity.